there's I guess a changing spectrum of patients with metastases with colon cancer. So from one end of someone having good prognosis cancer with one metastases with a high chance of survival or cure if surgery is done and systemic therapy is done, to someone who has more diffuse mets in multiple organs where we really don't have evidence for local therapies. And then in between is changing. In between is the unknown space. I suppose the philosophies of who to treat keep safety at the forefront, so only use radiation if it's safe, and biologically treat patients where there's a chance that they have oligomets or few mets, and it's not the tip of the iceberg where after a local therapy 3 to 6 months later there'll be diffuse mets, and to stage patients fully. So those three philosophies will help us choose. So anyone who's had prior radiotherapy as a child or hepatic arterial radiation therapy such as with Y90, I would say shouldn't be the first choice to go ahead with SBRT. And then with best outcomes in terms of the biology, there are different kinds of phenotypes. Natural history is one. So if someone has a natural history of having only a few metastases that perhaps waxed and waned with systemic therapy, more rationale to give a local therapy and with the chance of potentially long-term survival, versus someone who's had 20 plus metastases, like many go away with chemo and then different ones come up. Less rationale because probably there's diffuse micrometastases. In terms of the biology, other things potentially could be the markers. So looking at someone who has wild type P53, KRAS, BRAF mutations or wild type, they're more likely to respond to radiation. It's not an absolute contraindication to radiation, but it may impact the decision making. And then in terms of ability to give high enough dose safely, it's a little bit to do with the number and location of metastases. In general, off protocol, at my own institution, we have a philosophy for up to 5. It's a bit arbitrary, so up to 5 lesions in the liver. And we have up to 6 centimeters as the best outcomes are in patients with 6 centimeter tumors. It's not black and white, and there is evidence, including from my own institution, of treating larger tumors, but usually that would be a single large tumor, perhaps with a satellite. So I guess that's sort of the bottom line of the philosophy. I would, as I said at the beginning, advocate for standard of care local therapy, resection if it's safe, ablation, thermoablation if it's safe, but in locations where thermoablation may not be very successful, near vessels, in the hilum, near vasculature, near biliary system, that might be a threat for injury from thermal injury, I would prefer radiation. And if that is the local therapy, then can help the patient have good outcomes, we would use it. We don't always just use SBRT alone. So someone could have surgery for most of the lesions and SBRT for that central lesion that's not resectable. And similarly with ablation, there may be peripheral lesions treated with ablation, and it may be 1 or 2 lesions that aren't suitable. So together with a multidisciplinary team can make that decision. Absolute not, I would suppose at this point, diffuse peritoneal mets, brain mets, diffuse any mets, diffuse bone mets, probably even diffuse lung mets, that we can give SBRT to the lung and other sites. But again, we would want to be able to ablate all of the lesions and not just treat what we see if it's the tip of the iceberg. So it's not black and white. There's some definite contraindications that would be, we wouldn't treat radiation because of risk. But together with other team members, you can make decisions of when to treat with SBRT. So I don't know if that helped a little bit. I guess in terms of safety, so there's a little bit more risk for certain tumors in certain locations. So a metastases near the stomach or luminal GI tissues, there would be a little bit of dose that would go to those organs that would increase the risk of bleeding and or limit the dose that we can deliver. So that would be a situation where if there's another local therapy, I would suggest that rather than SBRT. And then in terms of remnant liver, so if someone's had a lot of surgery and has a small liver, we usually would like at least 400 cc's spared from radiotherapy, and there's different rules of thumb of how to do that, but that usually isn't a problem, and there's regeneration of the liver after local therapies, including SBRT. But yes, we do always want to keep a functional remnant after using SBRT.